Welcome to Easy Endo Prep's Endo in a Bite. I'm Dr. Sumbul Beg, and this podcast is your quick study snack designed for busy endocrinologists who want fast, board-relevant content that actually sticks. Whether you are preparing for initial certification, recertifying, completing the LKA, or simply staying sharp in clinic, this podcast is built for you. If you want my full board-focused system, visit easendoprep.com, where you can enroll in the complete Easy Endo Prep Board Review course or start a free trial. Imagine this scenario. A patient with type 1 diabetes is at home in the evening. They feel shaky, sweaty, and a little confused. They check their glucose, and the number reads 63. The question immediately becomes, what should they do right now? Should they treat? How much carbohydrate should they take? And at what point does hypoglycemia become an emergency that requires glucagon instead of food? Hypoglycemia is one of the most important safety issues in diabetes care. It affects patients with type 1 diabetes, patients with insulin-treated type 2 diabetes, and anyone receiving medications that increase insulin levels. Understanding when to treat and how to treat it quickly can prevent severe neurologic complications. There are 3 clinically important levels. Level 1 hypoglycemia is called the glucose alert value. This refers to a glucose level of 70 or lower. This level is not necessarily dangerous by itself, but it signals that glucose is trending downward and that action may be required to prevent further decline. Level 2 hypoglycemia is clinically significant hypoglycemia. This refers to glucose levels below 54 milligrams per deciliter. At this level, neuroglycopenic symptoms become more likely. Patients may experience confusion, blurred vision, difficulty concentrating, dizziness, or behavioral changes. This level requires prompt treatment. Level 3 hypoglycemia is severe hypoglycemia. This category is defined clinically rather than by a specific glucose number. Severe hypoglycemia refers to any episode in which the patient requires assistance from another person because of cognitive impairment. The patient may be unable to swallow, severely confused, unconscious, or even having a seizure. Here's the point: the glucose number alone does not always predict symptoms. Patients with chronically elevated blood sugars may develop symptoms at higher glucose levels. Meanwhile, patients with tight glycemic control or repeated hypoglycemia may develop impaired awareness and may not feel symptoms until glucose levels are very low. A helpful way to think about hypoglycemia management is a 3-step triad. First, determine whether the patient can self-treat. Second, choose the correct therapy. Third, reassess glucose after treatment. Start with the first step. Can the patient safely take oral carbohydrates? If the patient is awake, able to swallow, and able to treat themselves, oral carbohydrate is the first-line treatment. The standard recommendation is 15 to 20 grams of fast-acting carbohydrate. Patients should then wait 15 minutes and recheck glucose. If the glucose remains below 70, treatment should be repeated. Once glucose rises above 70, the patient should follow with a longer-acting carbohydrate or a snack, especially if the next meal is not coming soon. Patients often ask exactly how much food equals 15 grams. 4 glucose tablets typically provide about 16 grams of carbohydrate, since most tablets contain about 4 grams each. 4 ounces of orange juice provides approximately 15 grams of carbohydrate. 4 ounces of apple juice provides roughly 15 grams. 4 ounces of regular non-diet soda provides about 15 grams. Glucose gel is another option, and 1 tube usually contains about 15 grams of carbohydrate. The type of carbohydrate matters. Fast-acting carbohydrate works best. Foods that contain fat or protein, slow glucose absorption, and are not ideal for immediate treatment. For example, chocolate, peanut butter, or ice cream may eventually raise glucose levels, but they work too slowly to correct hypoglycemia quickly. Patients sometimes ask about candy. Candy can work if glucose tablets are unavailable. Roughly 5 to 7 jelly beans, or about 3 to 4 hard candies, generally provide around 15 grams of carbohydrate. However, glucose tablets remain the most predictable option. Now let's talk about when oral treatment is not appropriate. If the patient is unconscious, seizing, severely confused, or unable to swallow safely, oral carbohydrates should not be given. In these situations, there is a risk of aspiration. This is when glucagon becomes essential. Glucagon is the primary treatment for severe hypoglycemia outside the hospital. It works by stimulating the liver to release glucose through glycogen breakdown and glucose production. Traditionally, glucagon was available only as an injectable medication. The classic glucagon emergency kit requires mixing powder with liquid, drawing the medication into a syringe, and administering an intramuscular injection. During an emergency, this multi-step process can be difficult for caregivers without medical training. The usual adult dose for injectable glucagon is 1 milligram given intramuscularly or subcutaneously. In recent years, an important advance has been the development of nasal glucagon. Nasal glucagon is a dry powder administered into the nose using a simple device. It does not require injection and does not require mixing. Another advantage is storage. Nasal glucagon can be kept at room temperature for up to 2 years, which makes it practical for patients who travel or participate in sports. Clinical studies show that nasal glucagon resolves approximately 99% of severe hypoglycemic episodes within 30 minutes, with roughly half resolving within about 16 minutes. Because the device is simple to use, even individuals without medical training can administer it successfully. This makes nasal glucagon particularly useful in environments such as schools, athletic events, workplaces, or homes where trained medical personnel may not be immediately present. How do we administer nasal glucagon? Nasal glucagon, brand name Baqsimi, is given as a 3 milligram intranasal dose one time, and this same fixed dose applies to both adults and children age 4 years and older. It is not weight-based. The device is inserted into one nostril and the plunger is pressed and no inhalation is required. Because absorption occurs passively through the nasal mucosa, even if the patient is unconscious. If there is no response after 15 minutes, another 3 milligram dose can be given using a new device, and emergency services should be activated if not already done. This formulation does not require intravenous access or injection and can still be used in the setting of nasal congestion or an upper respiratory infection. Each device is single-use only, and once the patient is awake, oral carbohydrates should be given to prevent recurrent hypoglycemia. Now let's return to our patient. The patient checked their glucose and it was 63 milligrams per deciliter. They are awake, able to swallow, and able to treat themselves. This fits level 1 hypoglycemia. The correct action is simple. Take 15 to 20 grams of fast-acting carbohydrate, for example, 4 glucose tablets or 4 ounces of juice. Wait 15 minutes and check the glucose again. If the level remains below 70, repeat the treatment. But if the patient were unconscious or unable to swallow, the approach would be different. In that situation, glucagon should be administered immediately, either intramuscularly or using nasal glucagon. Let's finish with a clear summary of the key numbers. Level 1 hypoglycemia is a glucose alert value of 70 milligrams per deciliter or lower. Level 2, hypoglycemia is clinically significant. Hypoglycemia defined as glucose below 54 milligrams per deciliter. Level 3 hypoglycemia is severe hypoglycemia requiring assistance from another person regardless of the glucose value. If the patient is awake and able to swallow, treat with 15 to 20 grams of fast-acting carbohydrate. Examples include 4 glucose tablets, 4 ounces of juice, or 4 ounces of regular soda. After treatment, wait 15 minutes and recheck glucose. If the glucose remains below 70, treatment should be repeated. If the patient cannot swallow, is unconscious, or requires assistance, Glucagon should be administered. The standard adult injectable glucagon dose is 1 milligram intramuscularly or subcutaneously. For nasal glucagon, the dose to remember is 3 milligrams. Recognizing these numbers and acting quickly allows both clinicians and patients to treat hypoglycemia safely and effectively. That brings us to the end of the episode. I picked this topic after getting the newly released ESAP 2026 book and used it as a chance to review it with my own perspective. If anything went by too quickly, no problem. I've organized the key points for you. You can receive a clear summary with headings and bullets delivered straight to your inbox by visiting www.easyendoprep.com and signing up for the newsletter. New episodes come out every Monday. Keep listening as we continue learning one bite at a time.